It's the same small lung nodule, yet some people solve it with only 5 highly precise radiation treatments. It's the same nasopharyngeal carcinoma, yet some have precise planning and minimal side effects, while others suffer recurrence. Today, I'm taking you inside a real case discussion, 3 true stories where we translate the doctor's debates and consensus into health knowledge you can understand and use. First, let me spend 30 seconds clarifying the key terms that will appear repeatedly today. SBRT, the stereotactic body radiation therapy, simply understood, is the sniper of the radiation world, fewer sessions, higher dose per session, and super precise targeting, which offers better protection for surrounding healthy tissue. BED, biologically equivalent dose. Don't be intimidated. It's the unifying rule for comparing the total punch of different radiation schemes, just like converting miles and kilometers to a single unit for a side-by-side comparison. GTV/PTV. GTV is the visible tumor. PTV is the safe margin added around it, like cutting vegetables and leaving a border, not cutting right up to the edge. OAR, organs at risk. Key organs, heart, lungs, brachial plexus, etc., that must strictly adhere to dose limits to avoid injuring the good guys. Case 1, early stage lung cancer plus COPD. Our first case is an early stage tumor about 1.2 centimeters in the upper right lung. The patient has chronic obstructive pulmonary disease, COPD, and often experiences coughing and wheezing. The doctors focused on several critical steps. Completing the staging. A brain MRI with contrast is more reliable than a simple head CT. Even in early stage cases, we must check the entire body for external backup, metastases. Preventing radiation pneumonitis. This is one of SBRT's most worrisome complications. For patients with COPD, the team repeatedly stressed from during treatment up to a year afterward, live like an expert at avoiding colds, wear a mask in crowded places, and contact the doctor immediately if you have a fever. This is because many cases of post-radiation pneumonitis are triggered by infection. Planning and dosage. This example involved a small field irradiation. The radiation field is tiny and precise, like throwing a dart. The smaller the target, the more accurate the calibration needs to be. The team chose 1 to 2 common regimens. PTV 10 gray times 5 fractions, GTV 12 gray times 5 fractions, meaning extra force in the center area to achieve a high bead, or 7.5 gray times 8 fractions. A slightly more spread out total dose, balancing surrounding safety, protecting the brachial plexus. This nerve bundle is near the collarbone and controls arm movement sensation. Overdosing can cause upper limb weakness or pain, so it must be separately contoured and strictly dose limited. Adding medication or not, for stage in a early lung cancer, routine additional consolidation therapy, targeted or immunotherapy, is generally not recommended. Some studies suggest immune consolidation might improve disease-free survival, but it's not a blanket recommendation. It's more of an individualized discussion for higher risk patients. Case 2. Nasopharyngeal Carcinoma, NPC. Key changes in 2025. Avoid pitfalls. The second case is nasopharyngeal carcinoma. The nasopharynx is behind the nasal cavity and beneath the base of the skull. The anatomy here is like a multi-level interchange, so imaging must include an MRI for staging and an EBV-DNA test, which is one of NPC's fingerprints. New staging and planning highlights this year in simple terms are threefold. Sphenoid sinus involvement doesn't equal very late stage. More often it's T3. True T4 is more focused on skull-based penetration, invasion into the cranial cavity, clear cranial nerve symptoms, and the involvement of channel openings like the foramen oval and foramen laterum. Don't retreat the radiation too much in bone. Invasion areas, just because the tumor shrinks, the vulno-invasive region should in principle not be pulled back, as it easily leads to recurrence in the untreated area. Cervical lymph nodes, 50 gray to the positive node area is now more common. If there is extranodal extension, E&E, the contouring range and dose need to be correspondingly strengthened. Treatment pathway. Many centers follow GP induction chemotherapy, followed by concurrent chemoradiation. Some places also discuss the insurance eligibility of EGFR targeting monoclonal antibodies, but this varies by region and depends on local policy implementation. Planning, minefields, cavernous sinus, paracavernous regions, and skull base foramina coronal view MRI is often more intuitive. Planning is like both thoroughly eliminating the enemy and protecting key organs like the brainstem. The boundary delineation is a test of experience. Case 3. New upper right lung nodule, metastasis or second primary, real-world choice. The third case, the patient previously had cancer in the left lung and now a new nodule is found in the upper right lung. Is it a metastasis or a new primary cancer? Ideal practice. Biopsy if possible, like verifying identity before stepping onto the stage, but in reality, some patients refuse biopsy due to risk concerns or personal choice. In this situation, your treatment strategy changes completely. If treated as metastasis, many doctors opt for conventional fractionation, a lower BED regimen, but local control and long-term survival are often inferior to high BED. If treated as a new primary, the preference is SBRT or hypofractionation with a high BED greater than 100, such as 50 gray times 5 or 60 gray in 8 to 15 fractions, while also keeping the PTV expansion as small as possible to ensure accuracy and protect the surrounding tissue. Why is high BED preferred? Imagine you need to completely uproot a stubborn tree. The force must be sufficient and the direction accurate. BED is the ruler that measures total force. Insufficient BED is like only trimming the branches. An adequate BED is more like treating the roots as well. A planning tip: if treated as a metastasis, the CTV is usually not contoured, just GTV to PTV, because the biological behavior of satellite nodules is different. If treated as a primary, simultaneous boost can be considered, but you must ensure the tumor edges also meet the dose goal. Don't just elevate the center and starve the periphery. Conclusion: pathology is best. Without it, imaging features, location, morphology, time interval, plus overall risk assessment often lead doctors to lean toward treating it as a primary with SBRT, because the local control and survival data for high BED are consistently better in many cohorts. 3 actionable tips for patients. Don't skip imaging. For lung cancer, ask, did I get a brain MRI? For NPC, ask, are the MRO and EBV DNA results complete? Clarify the regimen's punch. Ask the doctor to explain the number of fractions, the BED, and how surrounding organs are protected in simple terms. Stay protected. If you are undergoing chest radiation, make infection prevention a long-term habit and report any fever immediately. Medicine is a race against time and a race against uncertainty. I hope today's session has translated the professional difference and consensus from the doctor's meeting into actionable guidance you can use right away. If you want to see more real-world, multidisciplinary team MDT discussions and little-known facts about radiation therapy, don't forget to like and subscribe and share this episode with those who need it. Let me know in the comments which type of case do you most want me to translate into plain language. I'll see you next time.